My name is Harry McMillan. I'm one of the directors of Momenta. We're your provider for the Type 2 Diabetes Path to Remission programme in Nottingham, Nottinghamshire. And this session is, I think, now the third of these that we've done, or the second, basically around helping you introduce the service to you, understand the referral process, and give you an overview of medication adjustments, and obviously answer as many of your questions as we can along the way. Should provide a small disclaimer, and sorry, I should also say I'm joined by Becky Wimbo, who is the contract manager here, so apologies for not introducing Becky. Becky will be, along with our engagement lead, Ramnik Singh, will be your day-to-day contacts going forward on the service. We've obviously got a wider team who support them behind the scenes. Neither of us are clinicians, but we've both been involved in delivering the service for some time. So if you have any questions that are too detailed for our knowledge on the medication side, then we'll obviously get back in touch with our medical director and get back to you. So as long as you understand we're not clinicians, but we are pretty familiar with the spec and the actual service delivery for many years, hopefully that will be reasonable positioning. So without further ado, this is what we're going to cover. So we'll talk briefly about the background and benefits of the service, the program itself, then our respective roles and responsibilities between yourselves in primary care and us as the provider. We'll then go through the medication adjustments logic for and the background to that for both blood pressure and blood glucose lowering medications, and allude to some others. And then Becky will take over to talk about the referral support, the referral form itself, medication adjustment form, and the next steps. So in terms of the background, the service specification and the whole genesis of this was basically the DIRECT study, which many of you may well have heard of. That was a piece of work funded by Diabetes UK between Glasgow and Newcastle universities. And there's also been other studies since, including Droplet, which have also informed the approach and specification. And these basically showed that remission of type 2 diabetes was possible at scale in primary care settings or through primary care referrals. In DIRECT, because this data refers to DIRECT, at 12 months, 24% of the intervention group, so almost a quarter, had lost 15 kilos or more. So that's a lot of weight loss for a lifestyle-based solution as opposed to a pharmacological or other approach, surgical approach. And then at 24 months, so at 2 years, sorry, I should say at 1 year, almost half had achieved remission at 46%. And at 2 years, that had dropped, but still 35% were in remission. And the intervention group also had fewer adverse events than the control group. Remission is very closely linked, or was very closely linked to weight loss. There's a very, very clear chart of people who lost 15 kilos or more had a 90% chance of achieving remission, and that dropped markedly, still about 60% for 10 to 15 kilos, and then significantly lower as the weight loss dropped. And remission for DIRECT and for this program is defined as having an HbA1c of less than 48 millimoles per mole off all diabetes medications, and having that HbA1c for more than 6 months. So there are other definitions of remission out there, but for this service, this is what's being used. It doesn't really matter. It's all semantics in many ways. And the reason it doesn't matter is that remission is obviously only achievable for, in line with the research, around half of the participants on the program. There are many other benefits which people will get from the service, which aren't just about their remission of type 2 diabetes. And that's why the name has changed to Path to Remission. That came out of lots of focus groups which Diabetes UK ran with patients who preferred the concept of a path to remission, and then also understanding that it was going to be an ongoing journey. So benefits for patients include significant weight loss. As you'll see later on, there's a kind of average of 11 to 13%, depending on contract area and demographics and such like. So 11 to 13% weight loss at 3 months. That's very significant and also in line with the direct study. In addition to the weight loss, which can be expected if people stick with the program, which is no mean feat, but if they do that, then there's also the possibility of achieving remission from type 2 diabetes. There's a significant reduction in medications for those on medications at referral, and there's also a impact on other comorbidities. So we get a lot of reports of improved conditions, as you'd expect from that amount of weight loss, from everything from sleep apnea, joint pain, arthritis, blood pressure, etc. So I guess that then leads to the improvements in quality of life and healthy living. And the entire program for 12 months is actually free of charge to participants. So that includes the products that they get. So it's not just the coaching, it's also the products. There's a link there which has lots of case studies, which you're very welcome to go and have a look at to see how people have really experienced the program, and that will help give you a better feel for it if you're talking to your patients about it, whether they ask you or you bring it up with them. From a practice point of view, it's a free service because it's commissioned by NHS England. The eligible referrals are will attract the weight management enhanced service fee. There are lots of anecdotal benefits of probably more significant benefits to the practice around reduced usage for people who have done well on the program, and also we and the ICB have developed quite extensive support to help you make the referral process as straightforward as possible. It obviously has, for many patients, the medication adjustments piece, which is different from other referrals, for example, to the diabetes prevention program. But we've tried to make that, as I say, as straightforward as possible, and we'll take you through that in due course. So as many of you will know, it was piloted as the NHS low-calorie diet program, including in Nottinghamshire, over the last 2.5 years or so. And the results of that pilot across the board had similar emerging results to direct. And so NHS England made it into a national framework like the NDPP, the Diabetes Prevention Programme. Fundamentally, the design is basically similar to direct, and it was a joint commissioning process. Many of you might not know much about us. That's because we set up a few years ago specifically to deliver these remission services. That was our primary intent. We've done some other things as well. But since February, since the 1st of February, we have been receiving your referrals. As previously, it was ABL Health until then for the previous couple of years. I guess nearby, we've been working in Birmingham and Solihull on the same service since 2020, and we're now working in 13 ICBs, which span from Dorset in the south to northeastern North Cumbria in the north, and a fair few around the Midlands. And again, I've mentioned our early outcomes are in line with the NHS England pilot. So what's the programme itself? There's 3 phases over 12 months. So again, follows the principles of direct. And the first phase lasts for 12 weeks, and that's the total diet replacement phase, or TDR phase. That's where your patients will basically replace all of their real food with 4 products a day. And we'll come on to some of those, but it's basically soups, shakes, or porridges. They have 4 products, generally, ideally, relatively evenly spaced throughout the day, to replace all of their real food. And they'll do that for 3 months. And the coaching that they'll get will support them, and the other materials and resources they get will support them through that journey. And obviously we'll prepare them for that beforehand. Come on to more of that later. And that's a total of 800 to 900 calories a day. Then the second phase, and actually bizarrely, if you haven't come across this before, or you haven't had patients referred to it before, but I say bizarrely because it sounds like a pretty hardcore lifestyle change program, and it takes a lot of commitment. But bizarrely, the retention rate over that period is very high. So when people decide that they want to do this and it's for them, they're really motivated, and they've shown that they really stick at it. The bit that they get often most worried about after the first week or two of adapting to the total diet replacement phase, the bit they get most concerned about is the second phase, so the reintroduction of real food. So this phase lasts 6 weeks, and every 2 weeks, the coaches will support participants to swap one of their products for a main meal, and eventually a snack, healthy snack. So that's 2 weeks per main meal, and they obviously do it in the choice that makes most sense to them and their lives. But that is quite a structured period of food reintroduction to help people get through their concerns. And then after that, up until a year, there's support, and that focuses more on the kind of traditional healthy eating, active lifestyle advice and support that you'd expect from maybe a diabetes prevention program or a tier 2 weight management program. But it happens from the point that the person has reached their lowest weight. So it's slightly backwards in terms of the positioning, because in those other programs, you're helping people gradually reduce their weight, whereas the weight maintenance phase here starts at a point where people are often at their lowest, or normally at their lowest weight that they've been for some time. Over that third phase, there's also a rescue or reset package for anyone who gains more than 2 kilos from their lowest weight. The delivery format is 1-to-1, and your patients will have a choice before they start of whether they want to experience that digitally, supported by an app, or in in-person clinics in their local community. So same program, same process, but obviously different delivery mechanisms. We use an organization called Habitual, who provide the total diet replacement product, and I'll come on to that in a minute. And they also provide our app platform. So it's our content and our coaches, but it's their platform. So before we get on to some of the detail, we'll just go through some of the eligibility criteria to understand who the program is for. We won't go into this in huge detail because of time, and you'll get these on the slides, and you'll also see these eligibility criteria on the referral and medication adjustment form. So just draw your attention to a few that sometimes are a little bit unusual if you haven't thought about this service before. So the first is there's an upper age limit of 65. So a lot of these criteria are designed to mirror the eligibility criteria for direct study, so that there's some comparison across the results. So upper age limit of 65 and relatively recently diagnosed with type 2 diabetes, so within 6 years of referral. There's an HbA1c limit, so an upper limit of 87 for everyone. And if they're on diabetes medication, a lower limit of 43 or above. And if they're not on diabetes medication, then a lower limit of 48 or above. And on the exclusion side, if people are on insulin, then the program is not suitable for them from a safety point of view. And if, in addition to these other category criteria, which you'd probably expect, it's also worth saying that if in your assessment it won't be possible to monitor patients' medications appropriately and safely, or it's not practical in a primary care setting if those medications are prescribed by secondary care, for example, or you just, for whatever reason of your own assessment, believe it is not a suitable program for your patient, then obviously that is a overriding reason not to refer them. So the program itself, I won't go into every session in huge detail, don't worry, but you can see the 3 phases in the different colors: total diet replacement, food reintroduction, and weight maintenance. As I say, this third phase focuses more on, the kind of content, healthy eating and active lifestyle content that you'll be familiar with from other programs like diabetes prevention. And the first phase is very much focused on psychological support and behavior change tools and knowledge and understanding, on the basis that that is the key to helping people stick with those products and shakes at the time. If also, it's not appropriate to talk about the food or activity when people are not meant to be doing additional activity and eating, not eating real food. So we provide additional resources, extensive resources for any in-person participants, and also for digital participants, as well as an app. Meal replacement products, they have a choice of 10 from Habitual. There's 2 porridges. There's plain porridge and banana porridge. Banana porridge is their best-selling item, in case you were wondering. There are 5 shakes and 3 soups. All of the products are vegetarian, 4 of them are vegan, and they're also all gluten-free. The way the process works is we provide your patients with voucher codes that are basically about a month's supply, and they order their choice, their preferred choice of whatever mix of products they want, which then are delivered to them directly, either to home or work, or wherever they want it delivered. And it's all at no cost to them, because they just use the voucher code that we provide them with. Just a brief overview, you can see different kinds of resources that we provide the in-person participants with, as well as a basic pedometer and recipe book access and booklets about TDR product. There's also an extensive workbook. These are all well laid out, they're interactive, they're extremely well thought of, and their resources are designed to help support people through the program, but also that they can keep afterwards as well and go back to, and that seems to be what people often do. In terms of the digital side, just a few snapshots from the app. So probably nothing you wouldn't expect. It's a clean, user-friendly, fairly intuitive interface. There's a bunch of different sessions in it, session plans, or lessons as I call it in the app, but the session equivalents. Each session then has a range of different modules that relate to each day. There's lots of different functionality on the bottom, you kind of things you'd probably expect. There's a log of achievements, there's FAQs, there's also gamification in the form of rewards, and there's lots of other tracking and other things that you'd also expect from an app like this. But it's again very well received from what we understand. So a lot of effort went into designing it, a lot of effort went into us choosing to work with Habitual and then putting our content onto it. So enough of the program, the background to it. Now looking at the actual roles and responsibilities. So it all starts with referrals. There is no service without referrals to it, and those referrals have to come from primary care. And they have to be sent to us on a referral and medication form, and we'll come on to that in more detail in a minute. However, before sending us the referral and medication adjustment form, you will want to talk to patients about it and potentially invite some of them for appointments in a more proactive way. And so we've worked with the ICB to come up with a range of different tools and resources to try and make that as streamlined for you as possible and give you choice to do it in a way that works best with you in the practice and how your practice is set up. So we've got patient information flyers, we've got landing pages on a website, there's a practice poster, there's an animation if you want to send that to patients who might be appropriate. There's searches, the referral forms are auto-populating. Becky will take you through that in a bit. Once you've sent us the referral, then we will do it, we'll check eligibility and get back to you with any questions on your missing information, and then we'll do an individual assessment and book people onto their chosen pathway, be that digital or in person. We'll then deliver the 3 phases of the program. And while we're doing that, really importantly, we will monitor some key safety information. So we'll monitor obviously attendance and weight, but also blood glucose for all participants and blood pressure for anyone who is on blood pressure medications at referral. Also monitor side effects, significant side effects and adverse events. So if those readings, we'll come on to the detail in a minute, but if those readings go outside certain thresholds designed by NHS England, then we will alert you either to suggest a medication review or to suggest a more urgent medication review if they're outside the sort of upper level threshold. We'll do that same day. We have a medical director who's a very experienced GP with a specialism in diabetes and lifestyle medicine. She reviews the communications before we send them to you to make sure we're not alerting you, bombarding you with false information or kind of unnecessary information. So she reviews that, but and also to provide any additional information that might be helpful to you when we alert you. Just for way of reference, we don't get many of these on the whole. So there are some people who do breach those thresholds, but they are relatively few and far between. But you'll see in a minute that the medications adjustments are very different, much more conservative than the direct approach, or the approach in the direct study, which was a bit more aggressive and required a lot more retitration afterwards. They've taken that into account, and this is a much more straightforward approach. So other than any medication or other review for patients, the other responsibility that you have is to do a 6-month and a 12-month HbA1c. Now, that's from referral, from the start of the program, but they can be, you don't have to diarise those. We'll send you a reminder. We'll also ask the patient to book one in. So there's no need to diarise them, and you can often use one of the annual ones you'd be doing anyway as part of that. So how to identify interested patients? There are 3 basic ways. The first way is to do a search and invitation. So there's searches that are available for your systems, and then you can send out, as we've drafted some invitation text, you can obviously make your own, but we suggest referencing the landing page, and that then patients can find out more about it, and the ones who are interested can come back to you and ask to be referred. So that's a way of making, just having conversations with people about this service who are both eligible, or almost certainly eligible, and then interested. The second way is in usual care. So be that on diagnosis of type 2 diabetes or on a medication review, or possibly at patient request. And then the third way is through kind of more bespoke events, potentially set up as group consultations, possibly in the evening to help meet enhanced access requirements. And we can talk about those in more detail, but some practices who are keen to do a reasonable number of referrals often look at combining, for example, the search and invitation with a group consultation event, as opposed to just having a series of individual one-to-ones. Either is fine and both work well. The third one, number 3, takes a bit more coordination. But again, we can support with that and also talk you through these other 2 in more detail if you need. So the usual care route is probably the most relevant for your patients, because that's when they'll be thinking about their type 2 diabetes. And this route, possibly combined with the group consultation approach, is the most efficient for you. And we probably get the majority, probably about 60+% of our referrals come through usual care across all of our contracts, just to give you an idea. But the search and invitation route is very popular for some. So I mentioned we have a landing page that basically provides your patients with more information about the service. They can download the leaflet that you could give them in practice, talks about what the program is, provides some case studies so they can see other people's experience of the program, eligibility criteria. Is it right for them now? That's really important before taking up your time to talk about referrals. So just helping them consider if it's the right thing to do now, and then what to do next. And we also signpost them to ask us about questions about the program if they want to, rather than coming back to you for that. So the idea is to help people who've been here only come to you if they're interested. Secondly, we have the case studies I've mentioned. So there's a whole page of case studies on our website. There's also flyers and posters for practices and an animation as well, which you can use and send to patients. The Slides are 2-page A4, so just to have quite a lot of the same information that we just been through on the website. And a QR code takes them to case studies, and then the poster is very simple, self-explanatory, same QR code. And we also have printed versions of these, I should say, that we can provide you with. So if you email Ramnik if you want printed versions for your practice or for an event, then we can provide those. Some of you in the past have asked, or your colleagues have asked, about where we deliver the program for in-person clinics. Obviously, that depends on where the people you refer live and work who want the in-person clinic option as opposed to digital option. So we don't have, it's not like DPP where there's a huge volume, so you know you'll be delivering in all areas of the contract area of the ICB. In this instance, we will focus our clinics on where people are who want in-person delivery. We don't have to wait for large groups. We can get going with a small clinic, but we've got these at venues identified. We'll very happily talk to you about more venues. We'll also very happily talk to you about delivering the service in your practice if you want. So quite a few practices and other areas have expressed interest in us delivering service in a practice for their patients. It's a one-to-one service, just needs a consultation room. So very happy to talk to you about that. So on to the medication adjustment piece. And I should say that all of this deprescribing advice that you would be providing to your patients is for the first day they start their total diet replacement products. So it's unusual because first it's deprescribing, not prescribing, and it's also because it won't be for immediate action. It will only be for when they actually start the program. We'll come back and reinforce that a few times. We will also talk to patients and make sure that they've understood and remembered that when we speak to them for registering them and for their individual assessment. So this data is from the counterbalance study from University of Newcastle, which informed DIRECT. And you can see on the left is blood glucose levels. And this is what happens in weeks after starting a total diet replacement diet, so stopping real food and calorie restricted. You'll see that blood glucose fell very sharply in the first week and continued to fall. And in this case, in these studies, this was after stopping all blood glucose and all blood pressure lowering medications. So despite stopping the blood glucose medication, their blood glucose came down very sharply and remained low. For blood pressure, it was a more nuanced picture. It came, systolic in particular came down, but to a lesser degree, but it still maintained lower, and diastolic to a smaller degree, as you'd probably expect. Again, this was after stopping all blood pressure lowering medications, so a much more aggressive approach. So this shows why it's necessary to deprescribe, because if people were on medication that continued to lower their blood glucose or blood pressure, and then you induce this kind of change, they could be at risk of having too low levels. So we'll go into this because obviously starting medication is more familiar than stopping them to many. There is a lot of guidance from NHS England, which we will signpost you to, as well as giving you these slides. These slides summarize that guidance, but the full guidance is available on the landing page for referrers. And it's been designed by an NHS England expert reference group to be safe and pragmatic and evidence-based. So it's informed by DIRECT and Droplet, but it's more conservative. So it is designed to be, and that means that we've seen in the pilot and these early implementations that there's far fewer retitrations, especially, well, there weren't many retitrations on the blood glucose side in DIRECT, but there were more on the blood pressure side, and the rate of retitration is far lower. So that means less work and less experimentation for you and patients. Importantly, the clinical responsibility remains with the referring GP. You have all of the information about the patient's medical history and other conditions, and the guidance that NHS England have come up with does not replace your clinical judgment. So if in your clinical view there's a good reason to diverge from the guidance, then then do so. I guess finally I should say, if you're unsure about making any referrals and unsure about medication adjustments, first speak with a colleague. There's also some support in the ICB to address that, and you can also get in touch with us and we can talk to our medical director and get back to you on any specifics. The vast majority of patients who are referred to this service have relatively straightforward medication adjustments, or indeed no medication adjustments if they're not on any medication. There are some that are more complex, but the easiest thing to do if you're uncertain about it is just to refer people with easier adjustments or no adjustments first. And then as you see the impact of the program on those patients and you gain a bit more confidence and understanding and talk to your colleagues, then you can potentially progress to people with more complex medications. So we'll go through blood glucose lowering agents first, then blood pressure. On the glucose lowering side, if there are no agents, obviously no adjustments. However, you will still need to complete the referral medication adjustment form to clarify that there are no adjustments and it's not just an oversight and you've forgotten the form. That's important from a safety point of view. If they're on one or two agents, then the guidance is to stop both of those. And this is, again, obviously when they start their total diet replacement products. If they're on 3 or more, the guidance is to keep them on metformin or other first-line agent if they are intolerant to metformin, with the exception of some that have safety concerns, which we'll come on to in a minute. And if they're on insulin, unfortunately, as we said beforehand, that's an exclusion criteria. Anyone who you are advising to reduce or stop medications on the first day of TDR, you should also counsel them about osmotic symptoms, about seeking support. And then, as we said, for all patients, need to complete the form, even if it's noting that there are no medications and therefore no change. And very importantly, just to reiterate to your patients that the change should only be made when they start their total diet replacement products. So in terms of a couple of 3 medications that are not safe with TDR products, sulfonylureas, triglycerides, and SGLT2s. So these are unsafe. The first 2 because there's a risk of hypo, and SGLT2s because a low-calorie diet also is effectively a low-carb diet, so the risk of keto. GLP-1s have a dotted red line around them because there's obviously a shortage at the moment and they're expensive, and so NHS England's preference is to reduce or stop those, but it's not a necessity. It's not a safety risk, it's more of a cost and affordability and availability issue. I mentioned that we'll be monitoring blood glucose, so if we flag that it has risen to more than 15, or your HbA1c at 6 and 12 months shows that it's risen, then you should consider restarting blood glucose lowering agents. So if they're not currently on a first line, then metformin or other appropriate first line agent is safe to put them on, even when they're in the TDR phase, and as are those other agents just there. But not sulfonylureas, triglycerides, or SGLT2s whilst they're on TDR. And if you think people need to start insulin, then they must stop the program altogether. So onto the blood pressure lowering agent side. The first thing to do is to consider blood pressure at referral. If it is elevated, so that's systolic over 140 or diastolic over 90, then there is no change. You would recommend to make no change to the medication. If it's within range, then, and this is where blood pressure is slightly more complicated than blood glucose, first identify any agents that are specifically and only for managing blood pressure, and stop the agent that was added last according to NICE guidance. We'll come on to a few examples of that, or the order on the next page. And we'll also come on to what to do if the medications are being used for indications other than just blood pressure, or solely for reasons other than just blood pressure. So, for example, for angina or heart failure. In any instance, when you're filling out the referral form and medication adjustment form, please counsel the patient about postural hypotension. So we have probably as many people who we have to flag to practices for blood pressure that has gone too low as it has for blood pressure that's gone too high. Sometimes that's because they have not been advised to reduce their blood pressure medication sufficiently. And other times it's just because they've done really well in the program and lost a lot more weight than necessarily anticipated. So advising them about symptoms of postural hypertension is very important, and we will do the same again before starting the program. Complete the form, even if there's no medications required, no medication changes required, and again reinforce it's only for when they start their total diet replacement products. So in terms of which medication to adjust, first thing is checking the notes and seeing if any of the medications are used for other indications we've talked about. If there is an agent that's purely prescribed for blood pressure, then changing the one that would have been added last according to NICE guidelines. So in order of stopping first, alpha blockers, beta blockers, spironolactone, or calcium channel blockers and thiazide diuretics, or finally ACE inhibitors and ARBs. So depending on where they are in terms of escalation of medications depends on what you stop first. So if your patient is taking agents which affect blood pressure, but all of them are being used for other indications, then that's where it becomes much more of a discussion with your patient and a decision to cautiously reduce the dose of one of those or possibly more of those agents, but in discussion, because it will depend on the circumstances. Again, if you're uncertain or unsure and it's safer not to refer or to wait, then do that. In terms of, again, if we tell you about threshold breaches, if blood pressure is too high, that's straightforward. You just increase or uptitrate according to NICE. And if blood pressure exceeds, so systolic is 180 or above and diastolic is 120 or above, we will advise same-day contact. We'll try and get hold of you in the same day or the following day if it's an evening clinic, and we'll advise the patient to do the same. Again, same thing is increase uptitrate as per NICE. If their blood pressure is too low, repeat the process you've just been through. And obviously prioritize the ones that are being used, the agents that are being used specifically for blood pressure. Finally, on medication adjustments, there are some medications which will need adjusting for people who change whose weight changes or diet changes significantly. So basically ask yourself, if someone lost weight or had a major dietary change, would that medication likely need adjustment? That's not normally something, so don't lose the weight immediately. So it's about putting in place appropriate monitoring to make sure that you can, with the patient, check them at an appropriate time. Again, if there cannot be a process put in place to adjust medications safely, then the patient should not be referred. And some examples, but by no means exhaustive, of those medications are things like warfarin. Actually, particularly warfarin is interesting because it's often impacted by, obviously, as you know, the kind of leafy greens and those sorts of things. So in the third phase of the program, so not even at the beginning, but as people start to reintroduce real food and potentially go to a healthier or a different diet from what they were used to having beforehand, then that could require monitoring. Also, DOACs and a range of others that can be affected, particularly by weight. So at this point, I will hand over to Becky to talk more about referral support. Thank you.
Yeah. So we're going to look at the referral form in just a second. So making the successful referral, as we've discussed, it's first of all identifying what's going to work best for your practice to identify eligible patients and to screen them before they come to ourselves. There's lots of support available, and if you're not too sure what's going to work best for your practice, do get in touch and we're happy to talk through how it's worked in other practices. Step 2 would then be to discuss the appointment with the patient. So we recommend allowing around 15 minutes, and this is from other referrers who've given advice on how long it takes their appointments with patients when they're making medication changes. Any practices that use some of the resources that we've got, again, this helps reduce the appointment time by the patient being quite well informed about what the program is before they come to yourselves. Once the medication changes have been discussed with the patient, and this is then put on the referral form to ourselves, we do advise that the patient also has a copy of this. Patients do sometimes get a little bit confused after their appointment if it's only done verbally around what medications you wanted them to stay on and which ones you wanted them to stop. The final step of the process would then be to send the referral to ourselves, and this NHS inbox is on the referral form. So if you have got questions before you refer and you want to confirm that the patient is eligible or suitable for the programme, do send us an email to that inbox and we will pick that up within our clinical team as well. So there's a few different places where you can locate the referral form. So firstly, for any practices who use EMIS and Ardens practices, the referral form is in the community tab at the top, and then you'll see it's the last option there that it says T2DR referral. That will then allow you to access the referral form. For Pathfinder practices, there's two places that you can find this. So you can find this on the diabetes or the lifestyle button, and then that will open up the second screen, which will then show you exactly where the referral form is within that as well. The last step of that, when you actually open it, you'll see, apologies, the quality is not great. There's patient information links there for you. So the referral form is there, but you've also got information there that you can send to patients, as well as some of the resources at the top as well. So all trying to put it in one place for you, as well as our overall website, which we'll show you. And then lastly, for system one, this would be then located in the referral directory, again at the top tab, and then it's the last option again, T2DR referral. If you've got any problems within finding referral forms, if you just send us an email with which system you're using, we'll help locate that for you. So the actual referral form, we'll just get that up for you and we'll just walk you through this. It will look slightly different if you have referred previously, but there'll be lots of parts that will operate exactly the same. So on here, as we mentioned, the information you've got there is prior to referring and has our inbox as well. So please do use that. If you've got a patient that you don't know if they're actually right for this programme and you don't want to refer them until you're sure, do email us. We're happy to help. So as you scroll through the referral form, it will pull through lots of the patient details. So lots of these grey boxes will pull through patient name, date of birth, name of referring GP. There's an option there to let us know the referrer's name. And if you are referring this patient, but you have had your clinical pharmacist or GP support with medication adjustment sign off, there's a point there you can also add to let us know who supported with that if we need to get back in touch with you again regarding this patient's medications. So most of this form will auto-populate, but what we have highlighted on here is places that the information will auto-populate but may be missed that the patient is actually not eligible or requires an up-to-date reading. So for example, date of birth, one of the common areas we find is we get patients over 65 referred, and date of diagnosis is probably the most common if we do have a patient that can't start the programme. The information will pull through automatically, so we just ask it as a quick check to see if they do fall within the 6 years of diagnosis. Patient information will then pull through for weight, height and BMI. Again, we do need a weight within the last 12 months and a HbA1c within the last 12 months. So as Harry said, the parameters are listed there for you as a reminder of what we would have to accept on the programme. The information here is just for information, so the eligibility criteria, if you want to refer back to and check before referring the patient, there's a full breakdown there. And you'll also have repeat medications pull through onto the referral form. So this is where you'll be able to check if any of them are impacting blood pressure or blood glucose in order to make a change when they come onto this programme. So this next section is all about medication changes. So we have a flowchart here, which is again as a resource for you. Once you're used to using this, you may not ever look at this, but while you're new to referring, it's a resource which goes through what we've covered today of how to make medication changes and what is the clinical guidance from NHS England for your patients. So important sections now, there's two sections that we're asking for medications. So the first is to confirm if patients are taking any of the medications listed on here, and to also let us know that the patient has also been instructed about these changes. As you then scroll through, you'll be asked to tell us exactly what those changes are. So this is what we call the medication adjustment table. And this is what patients can have as a copy in writing of what the appointment has discussed in regards to the medications. So there's an option to, as it will load in your form, you'll be able to click in and let us know the medication name, and then the action will be a stop, reduce, continue, or increase. Again, it does say there that changes are to be made on the first day of total diet replacement. So again, it's another good way for patients to have a copy of this so that they don't stop medications prior to actually starting on their total diet replacement. Again, what we've tried to do is just highlight some of the areas to be aware of so that if your patient is on an SGLT2, for example, that must be stopped to be on this program. And if they can't stop that, then it's not an appropriate referral to this service. And then at the very bottom, there's just a reminder again of our details on our website if you need to get in touch, as well as the SNOMED code for coding your patients as well. Great, thank you. So in terms of tips to use the searches and referrals, we've spoke about a few of them there, but these are just what we'll share in the slides. Although searches identify eligible patients on paper, it's that second part, which is the suitability for a program. With it being a 12-month program and a commitment to be on total diet replacement fully for 12 weeks, it's just around understanding that some of those patients actually may not want their referral in the first place, and to ensure that the information, although it pulls through automatically, it does meet our criteria for this program. If you do refer any patients where HbA1c is perhaps out of range or the date of diagnosis is missing, we'll let you know via email as well to the referrer what's missing in order to process the referral. Next slide, please. So this is one of our resources on our website, and it's a little bit of a recap of everything we've discussed today. So at the top, there are some interactive links, which you can use all of these from the website, but we'll also share around the slides for you. It also includes the link at the very bottom one is a link to book in with Ramnick. So if you've got questions after this session or at any point, or would like to go through options, talk about patient events, use that link to book in with Ramnick. So the first part of this programme, we do rely on people within primary care supporting to find the patients that are eligible for the service. So the two options we spoke about are the search and invitation, so running that search, seeing who's available, or through the usual care, particularly at data diagnosis, is a great opportunity to refer patients. Sending them the information, obviously they've got the optional option to go with us doing some kind of event within your practice for a group consultation, and allowing around 15 minutes for the appointment. And that's more for the slightly more complicated patients who may be on more medications. So if this will be a bit of a barrier for your practice, what some practices do is they focus on their newly diagnosed patients who are on less medications to get patients referred to this program as an initial wind of patients coming through. So once they then are referred to our team, we'll do checks. So we will make sure that the patient is eligible. We'll make sure we've got all the medication information that we require with all clear actions. And we will let you know, as I said, if anything is missing or if anything's unclear about the patient, we'll let you know in writing what that is before we process the patient. Once they then go through to our onboarding team, we'll then discuss the programme with the patient. They'll be given the chance to pick between the in-person or digital model, and we'll also fill in any knowledge gaps that they have as well. So if they're not too sure about certain parts of the programme, we'll make sure they do have a full understanding before starting the programme. Once on the programme with our team, we will make sure they have all the equipment, so that's all of their total diet replacement, as well as the appropriate equipment, depending on if they choose in-person or digital. So all of their measuring equipment will be provided to the patient. In terms of how we contact yourselves, so there'll be a few times we may get in touch whilst the patient is on the programme. And this includes patients who actually decline. Once they've been referred, they decline to start the programme, if they actually drop out of the programme, and if they complete the programme. We'll also let you know that HbA1c is actually still with primary care, so that does not sit with the provider. So we'll let you know that patients are reaching that point of finishing their total diet replacement and maybe due their repeat HbA1c. Patients are supported by our team, so we will be supporting them in terms of common side effects and managing those, but any patient who does let us know they've got a wider health concern will be signposted back for their usual care back at their GP practice. Next slide, please. Thank you. So next steps, I will be sending out this afternoon an email with some of the resources, a link to our website, which has lots of resources on, including the training video. So if you've got colleagues that didn't manage to attend today but would like to watch parts of the session. We also have, obviously, I've mentioned the booking link with Ramnik, so we'll send that across to everyone. We are very early on in terms of taking over the service, so we've been up and running for a few months now, but we're really happy to come along to any PLT, PCN, practice meetings, anything patient facing as well. We're really interested to come along and support to get people to know about the programme and how to refer into us. So please do let us know any questions or anything that we can help you with. We're happy to support. Great, thank you. And finally, to finish, we have some key contacts here, but you'll have all of this sent across to you. So if you've got questions, and you'll also be able to see who from the ICB as well. Adam will be your main contact from an ICB point of view if you do have questions that are perhaps more related to his remit. Thank you. Are there any questions, either in the chat or feel free to come off mute and we'll try and answer those for you.
So if someone has done the course previously, can they do it again at a later date? Yes, with a couple of caveats. So basically, if they've started total diet replacement, then they can be re-referred to the program 12 months after discharge from the first time they started it. If you had referred them to the service previously, either to us or to ABL, and they had not actually started, then again, you can refer them to us again at any point. So if they hadn't started total diet replacement, you can refer it again at any stage. If they've started it, finished it, or dropped out partway through, then it's 12 months after discharge. That's the official line. And I would say that NHS England are they're very firm on these cutoffs, whether it's the eligibility criteria or that side of things. They have almost no room for flexibility at this point. They used to a bit in the pilot, but they just don't flex anymore now. So I'm afraid we'll try and catch anything as early as possible and let you know if they're not eligible. But it's not us being too pernickety. It's just that we are literally not allowed to take people outside those points. And because we provide data to NHS England, they can see that. So there's no flexibility. All right. Anyone else got any questions? And we're happy to stay on for a few minutes if you do have questions or you want to talk anything through, or you've got any anything that's a bit more subtle that needs to discuss rather than just putting it in chat. And obviously, as we've got a few minutes, feel free to come off mute and ask.